Hey guys, welcome to PT Snacks Podcast. This is Kasey, your host. And if you're tuning in for the very first time, what you need to know is that this podcast is meant for physical therapists and physical therapist students who are looking to grow your fundamentals in bite-sized segments of time. Now, today we are going to be talking about the MPFL and patellar dislocation. But before we do that, if you've listened to the show for at least 3 episodes and you found it to be really helpful, if you wouldn't mind leaving a review wherever you've been listening, that would mean the world to me, because those really do make a big difference in terms of helping the show grow. But beyond that, we're going to review why this matters, which I think most of us can surmise that we don't want people to dislocate their patella. But also, what is the MPFL? What causes patellar dislocations? Who gets this? How do we assess for it? And then what do we do about treatment? It's kind of the outline for today. So without further ado, let's just hop right into it. Now, with these patients, we can see this non-op, post-op. We are very central to helping them get back to what they want to be able to do and try and do it in a way where we're not causing recurrent dislocations. Lateral patellar dislocations is mostly what I'm talking about in today's episode because that's the most common. Nearly almost always injures the MPFL, which stands for the medial patellofemoral ligament. Most patellar dislocations are lateral and occur in early knee flexion. So when I say early, I'm talking about like the first 20 to 30 degrees during twisting and valgus movement with the foot planted and the quad contracting. So when we're talking about the medial patellofemoral ligament, this is a ligament that is medial. It's kind of named where it is, right? So it's medial to the patella and it helps basically keep the patella from sliding laterally. If the patella dislocates laterally to the degree where that is no longer restraining it, the MPFL, well, it's probably injured in the process. So the MPFL actually in early flexion helps to restrain 50 to 80%. More than that, the patella itself is going to have a little bit more joint stability naturally to guard against that dislocation. But MPFL rupture and associated chondral damage is present in over 90% of first-time dislocations. So something we definitely want to keep into account with people who are experiencing these. When this happens, we see an increase in recurrent instability in 20 to 60% after the first-time dislocation non-op, which is a very large percentage span. And then we can also see a lot of early cartilage damage and later patellofemoral osteoarthritis, especially in our younger patients who had this, unfortunately. So who gets this? This is the clinical picture I want you to kind of picture in your mind. It's going to be more common in female adolescents who have a family history. They might have trochlear dysplasia, meaning they have a more shallow or flat groove. They might have patella alta, where it sits above the groove a little longer in flexion. So there's more of an unsafe zone with that early knee flexion that the MPFL is mainly restraining. So there's more opportunities for them to dislocate. They can have an increased TTTG distance, which is basically, it stands for the tibial tubercle trochlear groove distance. Now you know why they did the acronym. But it's an imaging measurement that they'll do on a CT or an MRI that quantifies how far laterally the tibial tubercle and therefore the patellar tendon sits relative to the deepest point of the femoral trochlear groove. So it basically measures the lateral pull on the patella. If there's more of a lateral pull, increased distance, it's already a little bit easier for the kneecap to dislocate laterally. MPFL insufficiency. If someone is generally lax, that's also a risk factor. And then also you can see this in more of a taller, heavier young male too. So essentially we're looking at genetic components that bias a patient to more easily dislocate laterally, whether it's because the joint itself doesn't have as much protection to keep it from going laterally, or there's more laxity, things of that nature. So those are our bigger risk factors. Now, acute lateral dislocations can happen in about 50 patients out of every 100,000. And the peak is going to be in females between 10 to 17 years old. Usually in sports where there's a lot of valgus and external rotation with the foot planted, or there could be a direct blow that dislocates the kneecap. So the positions we'll see a lot of times where it dislocates is when there's early knee flexion, and we're talking about the first 20 to 30 degrees of knee flexion. That person has their foot planted while they're twisting or have a valgus moment and their quad is contracting. That's the most common mechanism of when we see a lateral patellar dislocation. So how do we assess? A lot of times that patient, it's pretty obvious when it happens, but they'll have a lateral displacement with either a spontaneous or an assisted reduction, meaning the patella might sit laterally, and then as someone's trying to kind of help them, it pops back into place. They'll have immediate hemoarthrosis and an inability to continue activity, meaning pretty painful. They're probably not going to be going back to sport. The mechanism of injury, as I mentioned before, is going to be like a twisting valgus rotation near that 20 to 30 degree knee flexion. Imaging findings, generally they'll see an MPFL rupture in like 95 to 100% of acute dislocations on an MRI, and chondral damage in about 80 to 85%, whether it's on the patella or the trochlea, and loose bodies in 10 to 35%. So something to keep in mind, especially if your patient's struggling and it seems like more stuff is going on. Maybe more stuff is going on. In your exam, you might see if it's pretty early on, swelling, effusion, pretty limited range of motion. You can look at their patellar position. Yes, there is lateral glide and apprehension tests, or they can have persistent lateral translation, which would suggest MPFL or medial complex deficiency. But some red flags to keep in mind would be their knee is locking, there's a large effusion, you're suspecting a loose body and an osteochondral fracture. Also, something to keep in mind is if they have repeated dislocations or major anatomic risk factors, like what I mentioned before, that's also something we want to keep a close eye on. So that's the MPFL. Hope everybody's doing okay so far. But basically how we treat that, or at least a lot of what randomized controlled trials and meta-analyses will do for different situations is depends on, is it that patient's first time? Was it acute? Is it recurrent? So let's go through some scenarios. And obviously, this depends on the patient. What I'm talking about is just general. So this is not medical advice, right? So a lot of times in someone's first time, it's an acute patellar dislocation, they'll probably start out conservative. Now, they've also done some studies in people, skeletally immature patients who it's their first time. There was a randomized control trial where they compared repair versus conservative, and there was a similar return to function. So something to keep in mind. Again, that's one RCT. The first time in a mature patient with trauma, the meta-analysis actually showed better outcomes with the MPFL repair. And then someone with recurrent dislocations without bony dysplasia, an isolated MPFL reconstruction tended to be better. Now, last scenario, recurrent dislocation with significant trochlear dysplasia, patella alta, a large TTTG, distance, MPFL reconstruction plus bony realignment and tracheoplasty was typically recommended. So, but generally across the board, in someone's early phase, that patient who they've dislocated their kneecap, we're trying to protect, where those structures are irritated. There's already a lot of stress happening, so we're not trying to add a ton of crazy more stress, regardless of how quick that patient wants to go back to sport. We need to bring that down to a reasonable level and create a healing environment. We need to control pain. We need to avoid excessive lateral patellar stress. So probably not a lot of deep knee flexion with valgus. Working on things like patellar mobility, medial, superior, working on quad activation, hip abductors, extensors, core strength. That's more of what you might see in this stage. Then the goal, once we've got pain under control and we're starting to get some good activation, is we're progressing that patient towards normal walking, maybe we're doing closed chain strength in like 0 to 45 degrees and then 45 to 90 degrees, working on balance, perturbations, movement quality, that kind of stuff. And then eventually working towards full range of motion, trying to get that quad stronger, looking at a quad strength symmetry of ideally 90% of the other side. In our later stages, hopefully we are working on more strengthening, more return to sport activities, more with understanding what that tissue is ready for, and then progressing them later and later to things that they actually need to be able to do for their day-to-day, and utilizing tests to make sure that we are actually accomplishing what we need to. So some examples are quad strength symmetry. Are they like 90% within each other? And is there no particular order? Their anterior Y balance, step down tests. How do those look? Single leg hop test, lateral leap in catches, another example I've seen in research, a depth jump, things like that to see, are they physiologically ready? And then psychological readiness. So there's a lot of RSI scales specifically for the patellofemoral joint. There's the PFI RSI, MPFL RSI for patellofemoral specific RSI scales, and sport-specific drills. So see, is your patient psychologically ready to go back? Because fear can be pretty prevalent. And then just consider that while the patient in front of you may feel pressure to get back to sport or just really may want to go, a lot of the recurrent dislocators with only rehab, they had a 6-fold higher risk of persistent instability than MPFL or construction with rehab. And so in terms of the patients that you're seeing, knowing their history, are they post-op or non-op? And then in terms of a lot of these return to sport tests, on average, most patients were pretty poor at 6 months. So it may be more of a long-term battle, realistically, to actually get to the point where they're meeting those metrics that we'd want them to. So in summary, essentially what you should have gotten from today is patellar dislocations in the MPFL. What is the MPFL? When is it most needed? And when does it fail? What are risk factors that could predispose somebody to this? And then what do we do about it? Whether they're non-op, post-op, understanding if are they non-op? So that way we can make sure that we are progressing people appropriately. Now, again, this is just a brief episode. There's a ton of research on that, so I have some show notes in there. But if you have any questions, feel free to reach out at ptsaxpodcast@gmail.com. If I don't know the answer, I'll find somebody who does. And then if you're looking for more, again, I have a lot of research in the show notes. There's a plethora of information just for your light, enjoyable reading. Other things too, if you're in need of CCUs, MedBridge is actually offering listeners over $100 off their year subscription. If you're not familiar with MedBridge, they're actually a continuing education company that has like thousands of CEU courses, specialty exam prep, webinars, all sorts of information where you can, if you're trying to take a deeper dive in a lot of these topics, dive in there. So if you just use the promo code ptsnackspodcast@gmail.com, you can take advantage of that, or you can just go in the show notes. But other than that, connect with me. I'm starting a YouTube, so subscribe on YouTube, follow along. I've got some exciting things on the way. Follow me on Instagram at ptsnackspodcast. Join the newsletter. My goal this year is to really learn how to learn, so you can follow along with me on other tips of like just how to actually do that, and hopefully not feel like your inbox is being spammed. So all that information is in the show notes below. And yeah, I think I've talked long enough. So you guys enjoy the rest of your day, and I will see you later.